resident, consultant, oncoplastic breast surgeon and Professor of Surgery based in London, specialising in the diagnosis and treatment of diseases of the breast with over 25 years of experience. And now I shall read the bit that I was supposed to read now. Please welcome to our stage Professor Jayant Vaidya and his subject matter, how to make the breast cancer diagnosis better for patients. Please welcome him to the stage. Welcome, Professor.
Thank you very much.
There's your machine there. Okay.
Thank you very much, and thank you to Professor Sandlingham for inviting me. And it's a pleasure to see so many people in the morning and interested. I hope to be provocative, and I'm going to talk about, this is my potential conflict of interest, and I'll talk about 3 topics, hopefully in the next 30 minutes: screening, chemotherapy, and radiotherapy. So first is about screening. Screening mammography aims to detect breast cancer at an earlier and a more curable stage. Now, it's not particularly effective, but because it is to the whole population, it has some benefit. It takes between 500 to 2,000 women to be screened for 10 years to have 1 less breast cancer death. But what I'm asking you to think is this. If you do screening, in the years immediately after screening, women who have been screened should have a lower risk of being diagnosed with breast cancer. Does that sound logical? Okay. So I looked at this in Scotland, because in Scotland population doesn't move too much. And luckily in Fife, this is the place where Gordon Brown came from, the screening starts in January and ends in December. For the next 2 years there's no screening, and again starts in January. The van goes around in Fife asking patients to come. So what I found is I was plotting the number of invasive breast cancers. I'm not talking about DCIS, pre-invasive, I'm talking about invasive breast cancer, proper cancer. And if you look here, in the years before screening started in 1991, screening started, the incidence goes higher. The incidence was between 90 to 100 per 100,000. It's not population changing, and it is invasive breast cancer. It goes up every year because you're detecting cancers which would have otherwise become bigger. You're finding them early. Very nice. Right? There's a paradox there. You should have had this number was 90. Next year it would have been 90. It went to 150. You found 50 extra cancers, which would have been then growing later on in that person's lifetime, in that population. Well, you should have had a trough here, or here, or here. There isn't. Are you getting this? You find 50 extra cancers instead of 90 every 3 years, with no reduction in number of invasive cancers in subsequent years. What does it suggest? This is a very elegant demonstration of overdiagnosis. And the chairman of the ISD, which is the same as Office of National Statistics in Scotland, said, I can't get author on this paper because otherwise we'll stop screening. So overdiagnosis exists. And we found that women who are not being told about overdiagnosis before they go for screening have a horrible time if they find out about it when they are diagnosed. Because then nobody can really explain what to do with what we find, because they can't tell what's going to kill them, what's not. So, and we find that this paper, which was published last year, was quite a bit of publicity. I think at present, at least, we can't really tell. So at least acknowledge it exists. Inform women before they go for screening. It does not reduce attendance to screening. That is in a randomized trial. Reduce the impact of treatment by giving you minimum required for maximum benefit, and that's what I will come to in the next 2 topics. Try and understand the natural history of breast cancer and answer the $1 million question, and anyone answers this will probably get 10 Nobel Prizes. Which are these cancers which are going to grow, and in whom and when? Okay, so the second part I will talk about is radiotherapy during lumpectomy, which I think is better for patients. And I'm saying that because unknown to us, the NIHR put this up on their website, the 5 amazing health breakthroughs, not cancer, health breakthroughs, and put our research amongst those which are supposed to be among these 5. So it felt quite nice actually. It was COVID vaccines and COVID treatment. This was in 2021. So it was quite a nice surprise. And why might it be? It's because giving radiotherapy during lumpectomy for breast cancer while the patient is asleep, no radiotherapy, or a mastectomy, or giving whole breast radiation, 3/4 of patients chose to have intraoperative choose. And it is cost effective. And I thought this would be a very good thing, cost effectiveness, it's cheaper, it's much less expensive. But I was really naive, because if it costs more, it makes more money. And I never thought of that. So the chief editor of International Journal of Radiation Oncology, Biology and Physics, he put it in his editorial for the first time. And only after that I started saying this in public. He said this in 2016, that standard radiotherapy, fractional radiotherapy, forms a large part of practice of a standard radiation oncologist. So intraoperative radiotherapy can be considered either a quantum leap forward or a serious threat. So I never thought that would be a threat, because it saves money. It will save money. So it also is, this is a real paper which we found, it actually does reduce global warming. And interestingly, biologically, you find that after surgery is actually quite dangerous in some ways, because it stimulates growth, because it has to stimulate healing. Anything that stimulates growth, we found stimulated cancer cells. And luckily for us, if patient had intraoperative radiotherapy, the fluid collected from the wound, which otherwise stimulated cancer cells, stopped doing so. So it abrogated the effect of stimulation of cancer cells in cell lines by giving radiotherapy. So you can see, you may not appreciate it, but this has been measured. These move much more than these. This is bathing in fluid from normal versus those who received intraoperative therapy. And this is a paper that has come out on 20th of August this year from Winchester, in which 30 patients were asked how they felt about getting radiotherapy. And these patients received 5 days of radiotherapy, compared with 30, half of them who received standard intraoperative radiotherapy. So these are the things that patients have said. This was a qualitative study where it's an in-depth assessment of patients' perception. So 1 hour, 1.5 hours interviews with patients, and by an independent Sandeep Baka. These are the things that they said. I mean, essentially, it's a no-brainer for me. Absolute no-brainer. No side effects. I mean, this is what patients have said. Of course, we find 1 to 2% patients do get side effects, but they're no different in the randomized trial from standard radiotherapy. So it is really pretty good that they prefer this. But what I found interesting was, even those who had, most of these patients had 5-day radiotherapy, they felt the room is cold, you felt like a piece of meat. It was impersonal, it was aching, the breast was painful, and it was disruptive to their life, even though it is 5 days plus planning, plus in a quarter of patients, another 5 days. So nobody likes to do this, and when it is available, possible, it should be done. The long-term outcomes was possible because of collaboration of everybody around the world. Target A has one of the largest amount of data and follow-up, and what we found is that local control was no different between standard radiotherapy and intraoperative radiotherapy. Breast preservation was no different. Breast cancer death was no different, and this is a more magnified graphic magnification, but we found fewer non-breast cancer deaths, and that is a big difference really. It's nearly halving the chance of dying of other causes, and it is not a surprise because we know radiation, scattered radiation, even in smaller doses, causes damage to arteries. Within 6 months you get coronary effects and causes other cancers in the longer term. And what we found is there are fewer deaths from other causes. And in smokers, the risk of dying from lung cancer and heart attack is increased significantly, so that this is the Oxford paper that shows there's a 6% increase, so that quarter of patients nearly will die from heart attacks, lung cancer by the time if they were diagnosed at 50, by the time they reach 80, a quarter will die of heart attack and lung cancer having saved from breast cancer, just because of the radiotherapy. So it is, I think, unethical to offer this normal radiotherapy to patients. Overall survival, we found in grade 1 and 2 patients there was overall survival difference. So, and it is similar to that one would get with trastuzumab. The difference in terms of hazard ratio as well as that of absolute numbers is similar to these patients when they're given Herceptin, which actually damages the heart and costs a lot of money. And in grade 3 patients, there was no difference in overall survival. So this difference is not small. And this is, if you want single slide to have all the results, this is the slide that shows it. It was published in the BMJ and in the British Journal of Cancer, and that's probably the reason they said it. It featured on top of the Times on the day, along with Biden, who later on won the election. It has been recommended by NICE in centers that have the equipment, but it has not yet been implemented as much as we would have liked it to be. These are the results. So it is good for patients, really, that is in short. And it has been adopted around the world, as I've said before. So I have probably how long now left? I I have some time left, right?
5 minutes.
Pardon? 5 minutes?
10 minutes.
I finished 15 minutes, okay.
Oh, okay,
Yeah,
right.
yeah. Okay, so this is the third part I'm going to talk about. If you can load the last slide afterwards, which I sent earlier today, that would be nice at the end of the talk. So, new adjunct clinical activity. This is a paper I wrote in 2018, and just as I made enemies, I don't like to make enemies, I did, and there was very furious letter writing in the PMJ after this paper was published. What I was trying to say is, drugs before chemotherapy compared with drugs after chemotherapy, same drugs, we haven't found a survival difference. In 1991, we thought it would really make a difference. I was in Tata Hospital. We thought it was progressive to give chemotherapy before surgery. So we started doing it, and so on. It is the right thing to do. It is a novel thing to do. Why delay something that is ultimately going to make a difference to patients? Because it is a distant disease that ultimately kills. Why not start treating it as soon as you don't get the diagnosis? It was logical. So we started doing it. There were randomized trials. And this is the final answer, really. So this is what we wrote. Let us have a rethink. And this is because neoadjuvant chemotherapy is increasingly used, despite knowledge that it does increase local recurrence rate. But it's because we find that after you give neoadjuvant chemotherapy with the newer drugs, first we used to have 25% patients having no tumor left under pathology, which was fantastic. That number increased to 50, 60% now with newer drugs, new targeted drugs, and so on, which was so very encouraging and obviously logical to give, and it's difficult to define logic even with evidence. So I feel we should acknowledge this. Let's put chemotherapy in perspective. So this is what we base our chemotherapy treatment today on EBCTCG Oxford overview, and I've chosen just one of those pictures, which shows that giving anthracycline-based chemotherapy versus no chemotherapy reduces deaths from 40% to 35%. So it's about 5% absolute benefit of chemotherapy. Remember, this graph is up to 50% only, so if you make that graph to full, you get 100%. That shows that actually 60% patients would have lived anyways, even without chemotherapy. So there is a benefit of chemotherapy, and it took quite a bit of an effort to find this benefit, because the trials were originally very small, because people thought it would make a big difference. So, and this is a study from Institute Curie, which found with no chemotherapy and chemotherapy about 6% or 7% benefit. And for small cancers, the benefit may be smaller because there are many more might be cured by surgery alone. But we don't know that a person gets cured. You see, these graphs and data cannot tell us that. It may well be that for every patient, there is a 5 to 10% increase in survival because of chemotherapy. So every patient might increase their chance rather than some people being cured and some people not being cured. The other way of saying it is the probability of being cured is increased. Okay? So these are the benefits of chemotherapy neoadjuvant. To reduce the size of tumor that's not operable, this size which I feel still is an extremely good reason to do it. To reduce the delay in starting chemotherapy to reduce survival, unfortunately that has not been proven to be useful. To de-escalate surgery, but it may de-escalate radiotherapy and chemotherapy. There is a high chance of local recurrence that is proven. We don't have any evidence really of randomized evidence of reducing the treatment to the axilla. And to assess response to chemotherapy. This was another very beautiful idea, which unfortunately was not been yet completely proven. We could tell in the patient as a live test bed to see if this chemotherapy works for this patient. Most individualized way of actually making a management of patients in breast cancer. If a tumor is already taken out, you can't tell. So here you have a tumor in the breast that we can see if this works. If it doesn't work, then we give another drug. It's a very good system. So, but I'll show you the data. And add treatment if there's no response. And approve the same way pharmaceutical industry found it was so much better, rather than waiting for 10 years, why not get an answer in the first 6 months when you're giving the chemotherapy? So these were the various benefits. Stopped. Okay, but when you give neoadjuvant chemotherapy, you find that tumor disappears. The first warning came in 2005, where the recurrence rate was increased. And the latest overview found that equivalence in terms of overall survival, but it does permit more patients to have breast-conserving surgery, which is a very valid reason to give neoadjuvant chemotherapy. This is the unfortunate data. You find that if you add pertuzumab to trastuzumab before surgery, you find that the tumor disappearing completely goes up from 23%, 22% to 39%, almost doubling of complete pathological response rate, which is absolutely fantastic. This led to NICE approving the drug for giving before surgery. So it was not licensed, therefore it was given to patients before surgery because she would have needed chemotherapy anyway. It was all done with the full interest of the patient in hand. Unfortunately, when this trial of adjuvant systemic therapy, AFFINITY trial, was published and presented in ASCO in 2017 and then published in the New England Journal of Medicine, what was found is that overall survival, despite about 2,000 patients reaching 4 years follow-up, were really on top of each other. This is a paradox. Why would it not improve survival? And you have continued this, and this was difficult to find in the supplement appendix. 6 years follow-up was presented with nearly 3,000 patients reaching 6 years of follow-up. There was no difference in overall survival. This is such a disappointment when you know that the tumor appears to be disappearing. Now, that's why FDA did this analysis of pathological complete response and see whether that correlated with survival improvement. And what they found was this. If you look at this graph here, this is the hazard ratio of pathological complete response of drug A versus drug B in each of these clinical trials. So this line would find that this is the ratio of event-free survival, this is the hazard for overall survival. You would expect if there was twice amount of pathological complete response, the overall survival would improve twice. So this line should be a 45-degree line, the red line, not a horizontal line. And this is the reason why FDA has stopped approving drugs based on pathological complete response rates. And so the dramatic improvements in PASVCR do not reliably translate into better survival, and this has been repeatedly shown in Beatrice trial, for bevacizumab, NeoAlto trial, for nepatinib, and Neosphere and AFFINITY trials, where you get fantastic responses in pre-neoadjuvant setting. It's really disappointing in survival. Now the crucial question, there's two reasons for this, I think. One is that the breast cancer in the breast may not be representative of the breast cancer in distant organs. So therefore, even if a tumor is sensitive in the breast, which is what we find when we give neoadjuvant chemotherapy, the cells which have been spread elsewhere in the body may not be sensitive. So it may not be an indicator, reliable indicator of how the drugs will work. But there's another point, which is a calculation which I did with Dr. Nerurkar, a pathologist whom I work with, and Professor Michael Duet. He asked the question, how much tissue can a pathologist really examine? And I think this is a surprise to many people who have not yet done the calculation. It's a simple calculation. If you assess the volume and the proportion of operative specimen, this is the holy grail histopathology. That is a specimen, okay? That's a slide. One slice of tumor on a microscopy slide. It is 4 microns by 2 centimeter by 2 centimeter in size. What is the volume? If you multiply those, you get 0.00616 cubic millimeters of volume. And if you then look to examine a 1 centimeter diameter of tumor, you divide it, you need 625 sections. To examine a 4 centimeter diameter tumor, you need 20,944 sections. It would take 3.5 years. So assuming 20 sections are examined, which is done by a best pathology team, only 1,000th of a tumor is actually examined by the tumor bed is actually examined by the pathologist. 1,000th. If you go to this room, you see a small corner, you find no tumor there, you can say there's nobody here. I look in this corner, I say there's nobody there, that means there's nobody in this room. That is what is actually happening. That's what the pathologist, astute pathologist says, in what we examined, we didn't find the tumor. So if anybody has not seen the thing, this is what we find. So in response to breast does not correspond, that's a different talk which I've given you now. But pathology is a myth. They don't examine 99.9% of the tumor. So it may not be a good indicator of how well it responds. It may be possibly a good thing that you don't see anything in what you examine. And EBC-TCG meta-analysis found that it increases local recurrence rate when there is surgery done, and much more if surgery is not done. And it is much worse if you do less surgery. Mastectomy converted to breast conserving surgery. There's a much higher local recurrence rate. So the small difference in local recurrence might be acceptable if there was improvement in quality of life. But we don't even have improvement in quality of life. That has been proven anyway. Could it be dangerous? And there are some studies that suggest that exposing this tumor for 6 months to the drugs, when there are a lot of them present, might give evolutionary advantage to develop metastatic potential. ultimately we know that there doesn't seem to be a survival harm, but when you look at this meta-analysis, the power is not really as much to detect this small difference in possible mortality harm. And you may not always change from mastectomy to lumpectomy, and you would have a high increase in local recurrence rate. So, walking around for months with a cancer in the breast could have a psychological impact, and that's only one study as I found, which has done this, which found quite a lot more depression. And with surgery, I'm a surgeon, that doesn't mean I'm prejudiced for doing surgery, but this is the residual tumor with the best possible outcomes with chemotherapy first, whereas with surgery, you get in an hour, the cancer is gone. So, Catherine trial, I have another 5 minutes, it's 4 minutes. Catherine trial is the reason why patients with HER2 positive patients are given chemotherapy now in many often. Catherine trial found no overall survival benefit, and most patients in the trial had locally advanced cancers, and they did not have received pertuzumab. If you give pertuzumab, we really don't know whether DDM1 increases outcomes if there is no complete response to initial chemotherapy. So we are not really sure whether Catherine trial can justify it in patients who get pertuzumab, and it is expensive. It doesn't improve breast conserving surgery rate, adding pertuzumab, and for neoadjuvant chemotherapy for triple-negative breast cancers, we know capecitabine makes a difference to patients, but it can be given post-operatively as well. So that is not always a good reason, but for one thing, I'm looking at very interested immunotherapy, where it can possibly only work with the primary tumor being present in order to present the antigen and express it more, so that it makes a difference to patients. It may not work when the cancer is completely removed. If that shows overall survival benefit, that will give possibly one important reason to give chemotherapy before surgery in triple-negative breast cancer patients. And we don't really have enough evidence to de-escalate axilla for neoadjuvant chemotherapy. And when you do surgery after neoadjuvant chemotherapy, it is rather difficult conceptually. Because imagine that's the cancer, you give chemotherapy, put a clip in the center to tell us where it was before. We do that all the time. Cancer goes away, and then we remove the clip. It's clipectomy. It's not cancer surgery, and you may leave behind some cells behind, which is probably the reason why you get more local recurrence. It's not wide local excision. If we had a magic clip which attracted all the cancer cells towards it, then it would work very nicely, but I haven't come across this before, and not all of them may stay. No? So surgeons usually get this. I mean, at least we feel nice, and we get clear margins, cancer is all out, so we get claps, it's very nice. But on the other hand, when we say recommend adjuvant chemotherapy, so what? But I don't think this is a motivation really, that after neoadjuvant chemotherapy, we get complete pathologic response. Oh, wonderful, we all feel happy about it. But I don't think this is motivation enough. So I think it does give more chemotherapy to some people, and that's not really necessary. So I think we should think about it, and we should find a better method of testing drugs and give it to those patients whom it's really necessary. So I hope that has not been provoked too many enemies here. Thank you. And that's 30 minutes.